Right, it's 4:30. I think we'll make a start, Helen. So,
Yes.
welcome. Shall we start? So, good evening, everybody, and thank you for attending this webinar. This webinar is one of the events for the Croydon Women's Network, which is chaired by Sandra Bennett, who is a lead nurse for Croydon's Integrated Sexual Health Service. And she's my co-chair. I'm Rani Taka. I'm a consultant obstetrician and gynecologist working in Croydon for the past 20 years. I'm like part of the furniture, but I absolutely love working over here. So we could not think of a better event today. Today is International Midwives Day, and today we thought would be the best time to celebrate and best way to honor our midwives who really strive and work really hard to provide the best care for women in who deliver in Croydon University Hospital. So thank you all for attending. So today we thought the best way to celebrate this day would be to launch the Herd campaign. And the Herd campaign essentially has been created to improve the experience and outcome of BAME and vulnerable women during their pregnancy and the birth of their child. So really we need to ask ourselves, why is there a big issue? Well, this is what the midwives in Croydon asked themselves. And I really must thank Olumide and our team of midwives, Gina, Helen, who have put this together and really worked very hard. Dom as well, who is our consultant midwife. So throughout the program, I'm not going to waste time actually introducing each person, but I'll call you on and you introduce yourself and tell us what role you had to play in this. But really, I think it would be fair to say that this was Olomude's brainchild. So the thing is, we need to ask ourselves is why is there this issue and what do we know about this issue? So well, the statistics are out there and the statistics tell us the story. But statistics are numbers, and behind each number is a person. Behind each number, there's a mother, there's a father, there is a child, there are numerous child, there's a whole family. And if you look at the Embrace report, they have shown that Black and Asian women have a higher risk of dying in pregnancy. And this is not only the Embrace 2019, but it is also the previous Embrace audit and also the one done recently. What did this show us? Well, these are horrific statistics. As you can see here, Asian women are twice as likely to die compared to white women during childbirth. Even worse with mixed ethnicity women, 3 times, and even worse with Black women. And this is the same with neonates, the same kind of mortality, the same kind of awful outcome. Really, this is not acceptable. And then if you look broader, you will see that this disparity in outcomes is also seen with cervical cancer, cervical screening, breast cancer, endometriosis, miscarriages. Why is this happening and why should it happen? Really, we live in an era where we all should have equal health, and that is not happening. Now let's look at some stories. This is a healthcare worker. She was a nurse, Mary Agapong, who many of you must have heard of. It's been in the press. What happened to her? She developed COVID. She had to have an elective C-section, and she died after. Let's try and think why she died. Was it her color? There's not just one reason, but studies have shown that during COVID, this whole bad outcome was magnified. It's horrific. The statistics are horrific. They should not happen. Why do they happen? Well, it could be racism, structural, cultural, discrimination, social determinants of health, living in poor conditions, living in urban areas. And do you know what? Mary was a nurse. Her job was high risk. And really, we all should be proud of the job that we have done during COVID, because I think everyone's worked exceptionally hard. And I must say that I have never been so proud as I have been during this COVID crisis. It has been difficult. There's no doubt at all about that. It has been difficult. And this does not only happen to poor people, it doesn't only happen to working class people, but it happens to women out there, high profile women. Serena Williams had a problem. Many of you must have heard. She had a C-section, she had a pulmonary embolism, had to have anticoagulants, and developed a hematoma. And she has made this her campaign. This is what she said: every woman, regardless of race or background, deserves to have a healthy pregnancy and childbirth. And this needs to be everybody's motto over here. This cannot continue. And that is the aim of this herd campaign. So, what do we have to do today? Well, we all need to reflect. We all need to ask ourselves, why are we having these discrepancies? Each one of us need to pledge that we are going to make a difference. And let's start with our own maternity unit. Then let's look at ourselves and let's make sure that the baby on the right gets the same outcome as the baby on the left. The mother of the baby on the right gets the same outcome as the baby on the left. And we get rid of this disparity, because our mothers, our babies that deliver in this hospital or even in this country or globally need to get better care. Thank you very much, Helen. So we'll quickly move on to the next speaker. And our first speaker is Olamide Obisanwo, and she's going to tell us about how herd in maternity came about.
Thank you, Rani. So the Herd in Maternity campaign came about from basically the Embrace report. Time and time again, they've released statistics that show that Black, Asian, and minority ethnic women are more likely to die in pregnancy than white women. I've had many conversations with the team, the midwives at Croydon, and this kept going on. We discussed it and discussed it and discussed it. And it got to a point where I thought, what are we actually doing? Rather than discuss it, let's see what we can do at Croydon to improve these outcomes, to improve these experiences, to improve the care we give. We care for quite a large population of BAME women at Croydon. So it's only right that we try to address these statistics and do the best that we can do as a trust to improve these outcomes. I'm now going to move on to a short video from Davina. She's one of our service users, and she's going to speak about how the knowledge of poorer outcomes for Black women has affected her.
So I'm Davina. I have a beautiful daughter who's 2 years old that was born right in this, well, not in this room, but in one of the other wards. I had several midwives, and they were all brilliant. My pregnancy was positive. It was probably the best I've ever felt, to be honest. No, I had no idea it was that bad throughout my pregnancy and my labour. So no, I had no idea. I've heard hearsay through, say, my mum and people I know, but not. I didn't know it was literally a thing. So now I would say it's very worrying. Um, it's heartbreaking, and yeah, just disappointing that it's affected women in this capacity. Because obviously I've experienced institutionalized racism in other areas, but I just never knew it was a thing in hospital. That's true, I'd say, because in terms of I think I mentioned it briefly, institutional racism in other areas like the workplace. I don't know any black woman that hasn't experienced that, to be fair. And obviously the whole how you wear your hair, and that's all being looked at now, but like growing up, yeah, you couldn't wear your hair how you want, you know, to get a job, you have to carry yourself a certain way, we have to try 10 times harder. So that is true and that's real. And yeah, I definitely would say that all those stereotypes and hardships from those other areas can definitely filter through down to, you know, being in hospital, um, and the racial bias you might experience here or in that situation, I should say. It's hard. Uh, Probably be like reassurance. Maybe I don't know if there needs to be more training in staff, talking about it as well. Like instead of, you know, obviously it's not a nice thing to have to talk about racial bias and stuff, but talking about it really does help because then you recognise there is a problem. Um, Having more cultural understanding maybe within midwives, nurses, everybody from all backgrounds, making sure that they're, you know, aware that certain things are different, because I think that's where it can stem from as well, like culturally we might do things different. Probably, I guess, if you're talking about it more, maybe there'll be more programs about it. I don't know, like courses maybe. Uh, Obviously, reducing that statistic could be a sign that okay, things are changing. Obviously, that's going to take more than just talking about it. It's got to be looked into and stuff. Um, but I guess that's a way of measuring, you know, if progress is being made. Because yeah, the statistic is too high, to be honest, compared to other backgrounds.
Thank you so much for coming in to speak to us, because it's been really valuable and we're very privileged to have you here, so thank you.
Yeah, no problem at all. Thanks for asking me, and just keep up the good work. It's been a pleasure.
Brilliant.
Okay, hello everyone, good evening. My name is Dominique Warren. I'm one of the consultant obstetricians working at Croydon, and we felt it appropriate that we looked at what happens in Croydon, because I think it's really important that we focus on what we're doing here. Having these statistics nationally can make it almost seem like it's happening somewhere else. Next slide, please. So I wanted to look at a few factors about what's happening with our service users in Croydon. So we know Croydon is a diverse borough, with almost half of the people in the borough coming from Black, Asian and minority ethnic backgrounds. And our service users as well, the majority being from that background. And I've always felt that our staff reflects that. So are we still having these same situations here? Next slide. So I just wanted to look at a few outcomes just so we can make it a point that, you know, what's going on in Croydon. This is not supposed to be an exhaustive look at the house-wise, but it's really just looking at a few pointers that we know affect outcomes initially in the antenatal conditions, and then through delivery, and then through baby outcomes, and what's happening with our service users here. So I'm going to look at antenatal features. So the mean age across all ethnic backgrounds there was not much difference. With smoking, the majority tended to be white British at 46%, moving on to white other being 17%, and the Black, Asian and other minority ethnics being at lower minorities with smoking. I think particularly if you're from a clinical background working in obstetrics, we know that we screen for GDM and we put people through for GTT, but just making it clear that our Asian service users are twice as likely to develop GDM, being 25% of all our Asian service users will develop GDM, and we know that has implications on the pregnancy. With blood pressure and development of hypertension, again, it's been shown with our own statistics that Black service users are 1.5 times higher than white service users to develop hypertension and preeclampsia. Next slide. So we went on to look at sepsis, and it was found that Asian women on average were 2 times more likely to suffer with sepsis than any other ethnic group. And this is sepsis both antenatally and also postnatally. And we know that this can have real implications on morbidity and mortality, as seen in Embrace before, as one of the leading causes of death in maternal cases. But there was no significant difference in placental abruption, despite that concern of an increased higher rate with Black service users. Next slide. So with this discussion about racial bias, there's, I know, been a lot of discussion about pain and how our thoughts about how others cope with pain affect the way we manage people. And I thought it interesting, and this is, again, is just looking at some of our data, looking to see whether there's a massively significant difference on epidural uptake. This is obviously not the only analgesia on offer during labour, but is, I think, one that is very interesting. So I think what's interesting is that most of our service users, ranging from about 18 to about 20%, will have an epidural, but significantly Black Africans were at 15%, which was very much an outlier, and so were white Irish. And I know there's been, and there will be, some conversation later about concerns about racial bias and pain, and whether or not that's something that's significant here. Next slide. So mode of delivery, we thought, would be a good way to look at it as well. Are we having worse outcomes in terms of more ethnic minorities ending up with instrumentals or caesareans? Actually, we're doing really well at Croydon. Everyone across all ethnic backgrounds and white backgrounds are more or less having SVDs ranging within the 60% region. Interestingly, in instrumental deliveries, Black women were more likely to not have instrumental delivery, and there was no significant difference that I could determine with emergency caesarean section. Next slide. So we thought we'd also look at 3rd and 4th degree perineal tear rates. Our rate at Croydon, particularly with the implementation of OASIS, has shown to be 2.7% below national average, with Asian women the most likely to develop a 3rd or 4th degree tear. Next slide. So what about late miscarriage and preterm delivery? So late miscarriage is a loss between 14 to 24 weeks. And obviously these are devastating encounters that women will have to go through. Asian women are 7 times more likely than white users, and Black women 4 times more likely than white users to experience a late miscarriage. Preterm delivery, so we know that there's a national drive to reduce preterm delivery from 8% to 6%, but what we found is that we have an increased rate among Black women, 1.4 times more likely to deliver preterm than Asian and white women, and also 2 times more likely than those women who identify as other. Next slide, please. And then stillbirth. So stillbirth is delivery over 24 weeks of a non-live fetus and baby. And Black women at Croydon are 3 times more likely to suffer a stillbirth than white British women. And the white other group is twice as likely to have a stillbirth than a white British woman. Next slide, please. We also thought it important to look at neonatal term admissions. So there's also a drive to reduce the neonatal term admissions. And we've see on the pie chart the percentage breakdown of who has entered neonatal unit after 37 weeks. with Asian babies being the most likely, and that may be linked to the high rates of GDM and issues with hypoglycemia. And as we know, there's a lot of interlinking here that was not going to be fully explained today, but it's just nice to have these facts that we can kind of reach for. So Asian and mixed women have high rates of term neonatal admissions, twice the rate of white women at Croydon Hospital. And Asian and mixed women have 10 times the rate of neonatal admissions than those women who identify as other, with Black women with 7 times than women that identify as other. So generally across the board, higher rates. Next slide. So this is not the whole picture, okay? And obviously we're going to go on to talk about what else is going on other than antenatal risks. But it's good to have this kind of background that this is happening at Croydon. We are doing great work, but we need to look into more. And how is our bias and other things affecting the care that we're giving? Next slide. Thank you. And I think Olamide is going to be talking to us now about unconscious bias.
Thank you, Dom.
If I could just say that if you want to put any questions, please put them in the discussion bar over there. Please keep the questions coming because we'll answer them at the end, all of them. We want this to be interactive. We want to hear what you have to say. We want to hear how you think we can make it better. These are just initial thoughts. A lot more work needs to be done. So keep the ideas coming. We are open to any suggestion.
Thank you. So I'm going to be doing a presentation on understanding unconscious bias. Next slide, please, Helen. So first of all, just to describe what unconscious bias is. So it's defined as social stereotypes that we hold about certain groups of people that are formed outside our own conscious awareness. We have to remember that everyone has biases. It's not subject to one race or one factor. Everybody has biases. And what we need to do is to recognize the biases we have and address them in order to provide personalized care and support the women in our care. So I've listed some types of social biases, especially the ones that I feel kind of relate to midwifery and obstetrics that we may see. So first of all, we've got education level. So, think about how as healthcare professionals, we interact with people when we notice that, they don't have the same education level as us. We've got age bias, so looking after younger mums compared to older mums. Name bias, so thinking about a woman, if you see her in clinic, have you already made judgments about her based on her name before, meeting her or caring for her? We have socioeconomical status. So, looking at women, maybe the clothes they wear, the way that they speak, making those judgments before actually caring for them and allowing them to tell you what they want. We have race, ethnicity, and culture bias, which speaks for itself, really. We have disability bias and sexuality bias. So as healthcare professionals, please think about the biases that you may hold and, try and address them, try and think about how you as healthcare professionals can dismantle these biases, especially before caring for women. So how unconscious bias can present in healthcare. So lack of choice being offered, lack of support for women, and lack of informed consent. These top three, they make it seem like women are not being listened to. We time and time again hear that women are not listened to. And it's mostly because we're not giving them the choice. We're not actually supporting them and allowing them to make shared and informed decisions about their care. Not being offered pain relief. So as Dom talked about briefly, we've done a staff survey, which Helen will speak about, but one of the points in that spoke about how different women from different ethnicities cope with pain. So do we presume that, for example, Asian women do not cope well with pain? So when they're in early labour, are we actually offering them, the different types of pain relief? Are we giving them the care, or do we think, they don't cope very well, they're still in early labour? We really need to look at that. And also the stereotype that Black women cope with pain better. So Are we looking at our Black women that we care for and not offering them pain relief because we think that actually that they're fine? We're not giving them the choice. This leads to poorer care. And also another one is presuming care about a woman based on her name or ethnicity. Next slide. So potential effects of unconscious bias in healthcare. As I've mentioned before, it's lack of offering choice and consent, women feeling that they're not listened to and therefore having a lack of trust in healthcare professionals. It can potentially lead to misdiagnosis or lack of diagnosis, poorer experiences of maternal care, which we've heard time and time again from Black, Asian and minority ethnic women, poorer outcomes and health disparities and inequalities in care, as the Embrace report time and time again shows us. As Rani spoke about earlier, I put a picture of Serena Williams as well. I think it's quite telling to, see someone who is well educated, rich, well known, but still experienced poor care. She wasn't listened to. So we need to look at the women that we are caring for, think about how they may feel. If this can happen to Serena Williams, it can happen to anyone. So we really do need to try and address the biases we have. So next, I'm going to talk about some steps to eliminate unconscious bias. So really, first of all, it's really important that you know yourself and be honest with yourself. As I said earlier, it's really important that we know we all have biases, everyone, and it's about understanding those biases. Understanding what unconscious bias is. So taking some time out to read. There's so many articles, especially related to healthcare bias. There's so many articles. So doing some reading up so that you're aware of it. Self-awareness and reflection. So thinking about yourself, how you can improve as a healthcare professional, what biases you hold, and how you can try and eliminate those biases before caring for women. Question and respectfully challenge others. So if you see something that's happening in clinical practice or in your day-to-day, actually challenging that person professionally and letting them know that actually this isn't acceptable. Do you know that you've done this? Have you heard of unconscious bias? Do you feel you have unconscious bias? Really questioning so that the word is getting out there and people are able to have the opportunity to reflect on themselves and the care that they give others. Having conversations with family, friends and colleagues. So this is really important as well. There's so many healthcare professionals on this link now. We have healthcare professionals who are friends, who are families, just speaking about it so we're all aware. Unconscious bias doesn't just happen in healthcare. It can be any profession that anyone works in. So speaking about it helps to put the word out there so that we're able to improve. We are working on unconscious bias training at Croydon Hospital. We're looking for, the type of training that we're able to have that is actually tailored to midwives in order to improve the care so that it feels relatable and midwives are able to reflect on and have self-awareness. Celebrate our differences. So we are all different. We're all from different ethnicities, different cultures. It's really important to celebrate that in our day-to-day practice and embrace that, find out more and ensure that even for the women that we care for, allowing them to celebrate their differences with us. As part of this campaign, we've launched Herd Champions. So we're looking for staff within the trust who can help us to be present in the trust and help advocate for this campaign. It could be by speaking to staff, speaking to patients, being there to support patients or staff if they have any concerns, and just talking about the campaign. And my last tip is to be an advocate for women and their families. As midwives, for all the midwives who are in here, well, every healthcare professional, we are supposed to be advocates for the women that are in our care. So just remembering that and ensuring that we're doing the best for the women and their families in our care. Next slide, please. So my next slide is just about our, professional accountability. I looked on the NMC, the code, and also actually in the GMC, it talks about how we should treat people with kindness, respect, and compassion. Those three words there really emulate what we are supposed to do as healthcare professionals. Avoid making assumptions and recognize diversity in individual choice. Use a range of verbal and non-verbal communication methods and consider cultural sensitivities to better understand and respond to people's personal health needs, and act as an advocate for the vulnerable, challenging poor practice and discriminatory attitudes and behaviours relating to their care. So as healthcare professionals, we have a duty to do this. It's everyone that needs to be involved in improving these outcomes and, you know, checking their bias, ensuring they're giving the best care. So 3 takeaway messages for you all. The first is to know yourself and be honest with yourself. As I said previously, we all have biases. So just start thinking about the biases we may hold and start thinking about how you can, you know, challenge these biases that we hold as healthcare professionals. Get involved with conversations about unconscious bias, whether it's with other healthcare professionals, family members or friends. And just remember to treat everybody as an individual. You know, it doesn't matter if women are from the same culture, they have the same religion. Treat everybody as an individual. We need to listen to those women and give them individualized, personalized care. Thank you. So next it's going to be Helen, who will be speaking about our staff survey and sharing the findings from the survey.
Thanks, Olamide. Yeah, for those of you who don't know me, my name's Helen Chambers. I'm the project coordinator for Continuity of Carer and the Maternity Transformation Programme here at Croydon. I've been involved with the HERD campaign right since the beginning. I work very closely with Olamide in our usual jobs, and we have been having conversations for a long time about what we can do. So when Olamide said she wanted to set up HERD, I was fully behind her. Now, one of the difficulties that we've had with the campaign, and that I think we all have, is that whilst we know the outcomes, we know what the data says about the huge disparity in maternal outcomes according to ethnicity, what we don't have, which would make it much easier, but what we don't have is the reason for that disparity. There's no obvious findings that are coming out that show us exactly why these huge disparities exist. So when we're setting up the campaign, knowing exactly how to tackle a problem we don't fully understand is really difficult. But we thought what we could do as a starting point is to talk to our staff and to find out what their experiences were in caring for the very diverse population we have here at Croydon. Our staff happily reflect that diversity, so we are a really diverse workplace. But we wanted to ask people whether they had witnessed any discrimination, whether they understood what bias was, what they felt the barriers were to providing care, if there were any, and also what they thought the main causes for the disparity might be. So what we did, we designed a questionnaire, approved it amongst the HERD committee. We wanted to target all of the staff groups working in maternity. It's not just a midwifery thing, it's not just an obstetric thing. We asked everybody. So we asked anaesthetists, obstetricians, we obviously asked the midwives, the managers, admin staff, our support workers. We wanted everybody to get involved. One omission was that we didn't ask student midwives, which actually, if we did it again, we would do, but that was an omission. The survey was online. We used SurveyMonkey to collect data, and participation was voluntary and, importantly, anonymous. We wanted people to reflect on their biases in their answers, so it was important for us that it was anonymous. And we had the survey open for 3 weeks. We had 83 completed responses, and the completion rate was 78%. So that's good. This is a quick demonstration of the answers that we had. So the blue columns represent the percentage of all the answers from that group. So, and not surprisingly, nearly 40% of the answers were from band 5 or 6 midwives, because they are the most popular staff group. But the column in red shows the proportion of all the staff in that group that answered. So we had nearly 70% of our consultant obstetricians answer, and yeah, we had good representation. We also asked people which area they normally worked in. So again, labour ward was the highest representation, but we did have a really good set of answers from across all areas, community midwives, postnatal and antenatal wards as well. We asked respondents their ethnicity. What I couldn't get was a comparator of our total staff breakdown from HR. It would be really good to see how our respondents reflected our workforce. But as I said in the introduction, we do have a very diverse workforce, and we were well represented. So the starter question, we wanted to see what people's background knowledge was about this issue. So we asked them, based on the latest Embrace report, and a new one has been published since then, but how many times more likely is a Black woman to die in the perinatal period than a white woman? Happily, nearly 70% of people knew that the answer was 5 times more likely, but a significant number of people didn't know. And I think out of all the respondents, there were 42 individuals who answered this question incorrectly. And I mean, potentially part of our bias is that when we initially looked at that, we thought, is it that the people who don't know are potentially the admin staff, the support workers who need to know the research less as part of their day-to-day job? But we did actually look at the breakdown, and the people who answered that question wrong were from right the way across the board. There were midwives, there were doctors. Interestingly, 5 out of the 11 consultant obstetricians that answered did get that one wrong. So it just shows, I'm not trying to show up our amazing obstetricians, but what I am trying to do is just say that we need to do more awareness spreading across the board. It's everybody needs to know this. So we asked as well how important people felt that the following factors were in contributing to the increased rates of maternal mortality in women from BAME backgrounds. So there was quite an even spread across the board. We asked them whether they thought it was because women might not always engage with care, whether it was due to bias or unconscious bias, lack of trust in healthcare professionals, language barriers, socioeconomic status, or the fact that we know that women from some BAME backgrounds have a greater propensity for complications in pregnancy, like gestational diabetes or preeclampsia. So one of the things that came out in these answers, although they do on the face of it look very similar, is that people tended to go for the answers that people thought the most important factors were those that what we call the tangible things, the things that you can visibly see. So like having greater rates of diabetes or hypertension, or having language barriers, things that physically get in the way of care. And people were less likely to say that things like lack of trust in healthcare professionals and bias played an important part in the difference in outcomes. We asked people what their understanding of conscious and unconscious bias was and whether they knew what it was. 93.4% said that they did understand the concept. And we asked people if they were aware of any biases that they held relating to people of other ethnicities. Now, these answers were really interesting. 21% weren't sure, but it was pretty much 40-40 for those who said, yes, I am aware, and those who said, no, they're not. In the people that said yes, we had some really great reflective answers, like the ones demonstrated here. Really interesting one from one of our Black Caribbean midwives who said that sometimes with white patients, she felt like they were more likely to feedback about their care or vocalize, whether that was in a positive or negative way. And because she was aware that she might get more feedback, she tended to make a conscious effort to make sure her care to them was top notch. And she actually went on to say that on the flip side of that, she felt like women from BAME backgrounds were less likely to be informed about their care, and she often found herself dumbing down about that. Now, that's a really brave thing for that midwife to say, and she'd reflected on that, and she did say that she was actively working in her practice to counteract that bias that she'd recognised she had. And there's a really beautiful quote from one of our consultants as well, who said, we all have some bias. It is to recognise it and address it in life and in your practice. So for those like 37% who answered no to that question, a lot of their comments were, no, I treat everyone equally. No, I don't have any bias. And I think that is something that we want people to challenge, because we think everybody does have some biases, and it's not about treating everybody equally. It's about treating everybody as an individual and ensuring that everybody has equitable access to care. So we also asked people if they'd ever witnessed somebody being treated in a racially biased way by a colleague, and if they'd felt able to challenge that behaviour if they'd seen it. Now, just over 35% of people said they'd never witnessed racial bias towards a client. 20% said yes, and they had been able to challenge a behaviour. But about 23% said either yes, they saw it, but they didn't feel able to challenge it, or they didn't want to challenge it. And there are another 20% who are unsure. So 42.3% in total of those respondents had witnessed bias towards maternity clients. And I think that what the Heard campaign wants to do is to try and encourage people that if they do see that, they feel empowered to respectfully open the conversation and talk to their colleagues and say, maybe, did you realise that you said this in that way? And interestingly, even though on the last slide we saw that over 93% of people said that they understood the concept of unconscious bias, 72.6% of our staff said they'd like additional training in that area. So that's, as Olamide mentioned earlier, that's something that we're definitely looking into. So question 9, we asked if people treated the women they cared for differently based on their ethnicity. And this was it was a tricky question, because the people that said yes generally did it from a positive place. So they were saying, yes, I do. I treat everybody differently according to who they are, and ethnicity plays a factor in that. And conversely, the people that said no, a lot of them said, I don't treat them differently solely based on ethnicity. I treat everybody as an individual, which is right. Some of the people that said no, again, we had that idea of no, I treat everybody the same, which is something that we're trying to get away from, because everybody deserves to be treated as an individual. Question 10 was, do you perceive a difference in how women from different ethnic backgrounds cope with pain? And again, we had quite an even split on this, but about 47% of our staff said yes, they did notice a difference. There were two themes that really came out of that. One of them was the idea, actually this obstetrician said that in my experience, Asian and Black women tend to have higher pain thresholds, be less vocal about their pain, and revert to epidural less than white women. And that idea about Black women having a higher threshold came out in other comments too. What was a bit different about what this obstetrician said was that other people, including another obstetrician, felt that Asian patients tended to have a lower pain threshold and were less able to cope with sort of labour pains. And that can have a direct impact. Biases like that can have a direct impact on the experiences of our women, particularly on the antenatal ward, if they're undergoing induction or have been admitted in early labour. That's where we really need to raise awareness and make sure that we're not dismissing people because we think that maybe Asian women have lower pain thresholds, because it's a bias and it's not true for, waffled. This was similar to the first question about what people thought were the causes of racial disparity in maternity. But this was more asking what healthcare professionals felt were the key barriers to them providing the highest quality safe care to women from BAME backgrounds. So again, people clinged on to the idea that it's the measurable things, the tangible things that they didn't understand that they felt played a bigger impact. So that was lack of an understanding of clinical issues specific to BAME women. Language barriers came up and insufficient appointment time. But in this one, unlike in the first question, they said lack of time to build trusting relationships, and healthcare bias did come in there as well. So it's not as clear cut. We asked how people found caring for clients for whom English wasn't a first language and what their experience of using our translation services was. So people felt very positively. They strongly agreed that they knew how to arrange telephone and face-to-face interpreters, but they were less confident in saying that they always used official interpreters, or that they found it easy to access interpreting services. So working on how we access interpreting and what our sort of best practice guidance are is part of the HEARD campaign as well. Finally, we asked what interventions or service improvements we felt would most improve experiences and outcomes for the Black and Asian women accessing our maternity services. The size of the word, it means that it came up more in the answers, but there was a lot of questions about improving our understanding, use of interpreting services, time was a big one, and continuity of carer came up quite a lot as well. So the key themes to take from this is that idea of the tangible versus the intangible causes of adverse outcomes. In the answer to the last question, one of our obstetric colleagues wrote, first, we need hard data on what the causes of poor outcomes are, not individuals' opinions, facts. And whilst I do agree with that, we totally need the hard data. We don't have it at the moment, and years of Embrace reports hasn't been able to give us that so far. We need to keep working on it, and we're going to talk about how we're going to do that at Croydon later. But because we don't have those tangible causes, we need to start now in trying to do something and reflecting on the intangible causes, things like bias, is one of the things that we can do now. So we need to reflect on and challenge bias in ourselves and in others. We need to, I think, in maternity, looking at those specific biases that came out around pain tolerance in Black and Asian women, and really importantly for a lot of our clientele, improving communication and tackling language barriers. But Alamide and I are going to speak now from obviously we based what we wanted to do with the HEARD campaign a lot around what we found in our staff survey. So we're going to talk to you a little bit about that now. If you have any questions, I'm just going to remind you before we carry on, please do put them in the chat. I can see lots there now, but that's great. So Alamide, actually, I'm going to start with the first slide. So where to start? Obviously, I've just spoken to you about our staff survey, but following on from that, obviously the most important voice in all of this is that of the service users. So on the 1st of May, we launched our service user survey to find out more about how women experience our services, specifically those Black, Asian and minority ethnic groups that we're focusing on, and how we can improve care for them and outcomes. So we are going to use those findings obviously to inform the actions of the HEARD campaign, and we're hoping to present the feedback from that and our staff survey at the LMS patient safety event, which will be held on the 15th of June. And hopefully, time permitting, Alamide and I will write up our findings and maybe get them published.
Okay, so we looked at the booking appointment, which is the first midwifery appointment. We have designed a HEARD patient leaflet that we want all Black, Asian and minority ethnic women to have. We expect the midwives to have a conversation to inform women about the campaign, why it's come into place, and what we can do at Croydon Hospital, or what we're doing. Also, we've got it so that women are able to read it, find out more about themselves. It also speaks a bit about the pathway as well. We're increasing our booking appointments to 90 minutes. So one of the factors that came out in our staff survey is that staff felt they need more time for appointments. So that's something that we've done in the community. And we've also we're upgrading our detailed risk assessment and generating a personalised care plan for women. So as per Ockenden latest findings and recommendations, risk assessment is really important. We're trying to take ethnicity into account with this in creating our generating our personalised care plans. We want women to have informed choice, have shared decisions about their care. So really looking at things about choice of place of birth, ensuring we're offering home births to all women, the birth centres to all women. Next slide, Helen. So the next thing that we've also done is we've looked at vitamin D. So I'm sure you're all aware with the COVID-19 pandemic, Black women were more than 8 times more likely to be admitted with COVID-19, and Asian women were 4 times more likely to be admitted. So what we did is we ensured that we are providing vitamin D, Healthy Start vitamins to all women, all pregnant women at booking appointment, and giving them throughout the pregnancy. Next slide.
So yeah, a lot of the interventions that we've introduced are at the booking appointment, but we looked at the rest of the care pathway as well. A lot of that is about regularly revisiting the risk assessment and the personalised care plan. So at 16 weeks after we've had that screening and ultrasound. We also wanted to carry on the theme of giving midwives more time to build trusting relationships with the women. So at the 25-week appointment and the 31-week appointment, which have are done by the GPs, we're also going to reinstate a telephone appointment for all Black and Asian and minority ethnic women, in addition to that at 25 weeks. At 28 weeks, obviously, we're going to be revisiting the risk assessment again, checking that women have got enough of the Healthy Start vitamins and supplying those throughout the pregnancy. 31 weeks, an additional appointment there as well. And then at 36 weeks, again, going through that personalised care plan, the birth plan, and giving a longer 40-minute appointment there.
So the next thing that we looked at was interpreting services. In the survey, this was talked about a lot. So we, as staff, went to revisit the guidelines and the best practice for the use of interpreters. So we know that all women who do not understand or speak English will need to have an input of interpreting services. Face-to-face interpreters, we've changed it and said that, at booking 28 and 36 weeks, we need to have a face-to-face interpreter. And that's because vital information is given at these appointments. We do have telephone interpreters as well, which can be used at all other appointments. However, if needed, staff feel that actually they would benefit from a face-to-face interpreter. They are aware of how to get that. We've made it clear time and time again that family members and friends should not be used as official interpreters. We should always use official interpreters to interpret. We've got translating leaflets that we're working on, which we're going to put on the website so that women can access as well. And we're continuing to look at ways that we can improve labour interpreting. For women who, you're unable to book that interpreter, you need it quite urgently. We're looking at ways that we can improve that aspect of it.
So obviously the communication for the women that we care for, Alameda has shown the leaflet that we've put together. We're trying to raise awareness about the campaign, because the key part of the campaign for us is, aside from everything else, it's that the women that we care for know that we are here to listen. They know that we are trying to do something to help, and they know that they can talk to any member of the team, midwife, obstetrician, admin staff, whoever they come across, and be listened to. So we really want to put that out there. So we've got posters that have gone up in all of our patient areas, and we're working on getting those in all our GP surgeries and community clinics as well. We're putting stickers on everybody's notes. We've got a social media campaign running this week. And the other thing that we've got as well, we've got some nice new badges that have arrived. But the other thing is we want people to know that we are here to listen to them, but we also want them to get in touch with the campaign directly. If ever their care does not meet the standards that they expect, if ever they feel like they haven't been listened to, we've created a herd advocacy service where people can email us and get in touch and talk in more depth and about those issues, so they know that there is always somebody here to listen.
So for healthcare professionals, the communication we have, so we have the first leaflet that you see there, the blue one, consider your bias. It's basically a one-stop reminder for staff to check their bias, consider their bias before they provide care for a woman. So it's stop, look and listen. We've put those in all areas where patients are seen, on labour ward, antenatal clinic, antenatal postnatal ward. And we also have a leaflet that we've designed, or Helen has designed, about best practice for use of language line. So we really want to ensure that staff are aware of how to book interpreters and are booking them as per our guidelines, which we've actually updated. So the next thing, bias training awareness. So I've spoken previously about cultural competency and unconscious bias training, which we're planning to implement in the trust for all our midwives and hopefully other healthcare professionals as well. We have our herd champions that we're looking for within the trust. So if there is anyone in the call who wants to become a champion, please email us. Our email address has been in the presentation. And if you see any of the posters in the trust, they are there as well. Obviously, doing this launch on International Day of the Midwives, we've been around to speak with midwives. We've shared the posters that we have. We shared the fact that we're doing our service user survey, all the leaflets we have for our patients, which we've actually translated as well in some languages for women who are not able to access online. We just want the word to go out there and ensure that women know what we're doing and know that actually we are thinking about these disparities and hoping that we can make some sort of a change.
So the other point that we are working on, we've mentioned that there is a lack of research to give us clear-cut causes for the difference in outcomes. So our amazing medical director, Dr. Nona, has led the recruitment of a Darcy Fellow to undertake a deep dive audit into the outcomes for all women in Croydon, but looking specifically at the outcomes based on ethnicity to give us that really, really strong understanding and the data that we need to identify targeted areas for clinical improvement. We also, the campaign, we are not alone. The LMS, our South West London LMS, have put together an equality and diversity working group that we're working closely with, and it's about just keep on going. Like, we're very aware that we're starting something, but it's about working with everybody to keep going and to keep developing. So that's where we are at the moment. We are now going to hand over to our amazing colleague Sandra, talking about working across professions. Sandra is one of our sexual health practitioners here at Croydon, and she is going to talk to you about HERD from a sexual health perspective. Are you able to share your screen, Sandra? Oh, you're on mute.
Okay, good evening, everybody. I'm Sandra Bennett, as Helen said, and I work just across the road from the maternity unit at Croydon University Hospital. I'm also one of the co-chairs, as Ronnie mentioned earlier in the introduction, of the Women's Network, and very excited to be part of the HERDS project and being invited to work collaboratively with this amazing maternity team. So our part in the HERD project, as you know, sexual health or sex being the first profession in the whole world, maternity being the next profession, we want to work together with this team, and we are currently working together. Um, the sexual health department with the maternity midwives, antenatally, postnatally, and in the labor ward. In the fact that we have got a direct pathway for our young persons to our young persons, vulnerable young people, to access sexual health services for their sexual health needs, whether it be infection or talking about future contraception. We work directly with the midwives for these young people just before they get into the, to deliver, so that we can make contact with them for their aftercare, postnatal care, with regard to early intervention for their contraceptive needs, as well as their sexual health screening, if that be the case at the time. We are also working with the postnatal team in providing postnatal contraception for all women and making every contact count. So on the wards, most women will be provided with the progesterone pill, and should they choose to have the contraceptive implant, they have a direct pathway to the clinic. We would either go to them or they could come to us, and we also provide them with future intrauterine insertion appointments. So we're working really, really closely with this maternity team here in Croydon. And just moving on, talking about the most common sexually transmitted infections, we look at chlamydia being the most common sexually transmitted infection, followed by gonorrhea and genital herpes and genital warts, which I'm glad to say that the statistics for genital warts is now decreasing due to the access and the acceptance of the HPV vaccination. And my part in talking about sexual health education and sexually transmitted infections is how it affects the woman and her baby, and affects the statistics that Alamede and Helen and her team have been talking about. And you'll see there is actually a direct correlation between the stats. Where the under 25-year-old group remains the highest group who are affected by sexually transmitted infections. So how do the STI, sexually transmitted infections, affect pregnant women? You'll find that, so when we talk about syphilis, this can cross the placental barrier and affect the baby. And other infections like gonorrhea, chlamydia, hepatitis B, genital herpes, they can pass from mother to baby through the birth canal and affect baby that way. And these have got very dire consequences for our newborns and neonates, especially genital herpes, which can be really fatal for our babies. Chlamydia can cause blindness, and also HIV can cross the placental barrier as well during pregnancy and during delivery and infect baby. Okay, and then you can just imagine these have got negative consequences for mother and baby. Okay, so what are the effects of sexually transmitted infections then on the baby? These harmful effects on the babies can include pneumonia, low birth weight under 5 pounds, and of course you will know that these are just unacceptable for the neonates. And then eye infections, which can lead to blindness, septicemia, which can be fatal for the baby and for mom, and brain damage, lack of coordination and body movements, as well as deafness, acute hepatitis, meningitis, and stillbirth. Okay, and needless to say, the outcomes of these are, are not desirable. So I'm just trying to let you see the correlation from a sexual health point of view. Okay. So I'm now going to give you some of the results from the State of the Nation report, which was done in February of 2020, and just talking about the key populations affected by sexually transmitted infections, and understanding the intersectionality of the data is really important to see, again, where sexual health fits into the agenda. Now, although STIs can affect anyone, there are certain groups that experience disproportionate rates of sexually transmitted infections, and these would include your young people living with HIV, sexually people who have men who have sex with men, and specific ethnic minority communities, as well as people from ethnic minority communities account for 1 in every 5 of the sexually transmitted infectious diagnosis. Now you'll see that is exactly as the ladies reported, that 1 in 5 women are disproportionately affected, and that's 20% of our ladies, and that is 20% of our population here. There are obviously differences in sexually transmitted rates, infection rates by ethnicity, with Black Caribbean individuals and Black non-African and non-African, non-Caribbean individuals generally seeing the highest rates of new diagnoses among many sexually transmitted infections, particularly gonorrhea. And that will just sort of fits in again with the HERD project of the communities that we are looking at. So individuals from ethnic minority communities account for 20% of sexually transmitted infections, as I said before. Now, Public Health England's 2018 report on sexually transmitted infections found that young women are more likely to be diagnosed with a sexually transmitted infection than their counterparts. And of all the young people diagnosed with a sexually transmitted infection in 2018, 64% of the men were men, and more than 99% of the women were identified as heterosexual. So the statistics are really, really high, influencing negative outcome for our pregnant women and their babies. Then we can clearly see that people from marginalized groups who often experience discrimination are bearing a proportionate burden of sexually transmitted infections. And both socioeconomic and circumstances and ethnicity were found to be an important factor in the increased rates of sexually transmitted infections amongst Black, Caribbean, and non-Caribbean African ethnicities in England. So the lack of sexual health education, we know, will have poor economic outcomes for our community, both men and women. It will contribute to the unplanned and unwanted pregnancies, as well as increased sexually transmitted infections and increased first and subsequent abortions, and also the loss of education and employment. And as much as we're talking about the absolutely detrimental effects of our women in the maternity unit and their babies, this lack of sexual health education has got a wider implication that will continue to influence the negative outcome of our women if something doesn't change. It influences the loss of education and employment, causing most of our young people to be in the category of what we call not in education and employment due to unplanned pregnancies and terminations maybe. And also teenage parents being likely to be solo parents, adding to the socioeconomic negative outcomes for these young children, as well as increased mental health and sexual violence. Okay, and just moving on then to say that the UK retains the highest rate of teenage pregnancies. leading to low expectations for our youngsters, a lack of accurate knowledge about contraception, and unfortunately getting mixed messages from the adult world. Just a little bit of good news with all that doom and gloom that I've given you right now is that since 2010, with the introduction of the contraceptive implant, or the wider acceptance of the contraceptive implant, the conception rates for women under 18 years of age has halved in both the most and the least deprived areas in England. And this is really due to the contraceptive implant. And now, more so than ever, more youngsters and more people who haven't had a delivery before are accepting the intrauterine device or system, commonly known as the hormonal and non-hormonal coil. And the more and more of our clinicians who are becoming empowered for fitting these coils, which historically were mainly left to the medical clinicians like the doctors to fit them. Now our nurses are getting more and more empowered and trained up to fit them. That means that more and more of our women are having access to early intervention contraception, leading to a decrease in unwanted pregnancies and making women have the choice to have a pregnancy when they want to. So one of the things we talk about is probably looking at a framework for sexual health improvement, and our last framework was done in 2007, sexual health framework, and we are desperately in need of a new framework just to looking at these disproportionately affected groups of people, and the framework that would be effective in addressing these inequalities would be to reduce the inequalities and improve sexual health outcomes, to build an honest and open culture where everyone is able to make informed and responsible choices about relationships and sex, and recognize that sexual ill health can affect all parts of society. And also to continue to tackle the stigma and discrimination and prejudice that most of our people, especially in the Black and Asian minority ethnic groups, are experiencing, as proved by the bias report that Alamedy presented earlier on. Okay, and a good framework would also help to continue to tackle the stigma and the discrimination and prejudice, like I said, to support women with unwanted pregnancies in making informed decisions about their pregnancies, and to continue to tackle HIV through prevention and increase access to testing. Promote integration, quality, value for money, and innovation in services. And also for women to have access to a full range of contraception, leading to reduced pregnancies, and encourage dialogue around the sexual health agenda. So my message is very short, and I'm coming to the end of it. So for far too long, the inequalities that exist in regards to the burden of STIs have been ignored. And it's about time now that services, commissioners, policymakers must now acknowledge that these inequalities can no longer be ignored, that they exist. And also that in the face of such stark inequalities, the lack of research into the structural drivers of sexually transmitted infections in communities who face disproportionate burdens of sexually transmitted infections is unacceptable. Therefore, the Department of Health and Social Care, working with Public Health England as well as the local authorities, must take affirmative action to tackle these inequalities and address them head on. Understanding the trends and the inequalities related to sexually transmitted infections is key to improving the sexual health of those affected. And the vision then is, this is really an urgent need for a clear, cohesive, and a comprehensive strategy that reinforces responsibilities, helps to address current challenges in the system, and sets out a clear ambition to tackle sexually transmitted infections which have a direct effect on the pregnant mother and her baby. Thank you.
Thank you, Sandra. Thank you very much for that talk. We'll next move on to the talk by Beverly and Victoria, who are our co-chairs of Croydon Maternity Voices Partnership. Are you here, Beverly and Victoria? I've seen Victoria in the chat there. Yeah.
Miss Thacker, we've got a pre-recorded video that I'm going to share. Can you see it?
Lovely. I've seen them in the chat though. So they are here. Yeah.
Hi everyone, I'm Victoria. I'm a mom of one Croydon baby with one on the way, and I'm also the co-chair of the Croydon Maternity Voices Partnership.
Hi everyone, I'm Bev. I am also a mum of one, and I am co-chair of the Croydon Maternity Voices Partnership. So the MVP is a group of people from all backgrounds: maternity workers, commissioners, family support in the community, but most importantly, families. Mums and dads who have first-hand experience of using the maternity services at Croydon. So our role is to hear the voices of these families, also known as our service users, to raise their voices up and find the themes where the service can be transformed for the benefit of those who use it. The Heard campaign is an exciting development for Croydon, where work is being done to challenge our current views and beliefs, because this can affect the way that we treat each other.
We know we have a diverse community in Croydon, and it's our aim as an MVP to help everyone from all corners of our community to be heard. This campaign can go a long way towards making this possible. We're looking forward to supporting and collaborating with everyone involved and to co-producing a service that puts families at the center of the care we provide in Croydon.
Thank you, Beverly and Victoria. And now, last but not least, we have with us Belle Ribeiro Eddy, who is an MP. We are really lucky to have you here. Belle is a British Labour Party politician who served as a Member of Parliament for Stratham since 2019 general election. She considers herself a lifelong socialist and a feminist, and was briefly Shadow Minister of State for Immigration in 2020. And she is absolutely passionate about this topic. Welcome, Belle, and thank you so much for joining us today.
Thank you. Thank you very much for inviting me to speak. I'm so pleased to hear about the launch of Heard and all of the work that you've been doing. It's so key right now that different hospitals are taking it upon themselves, different trusts and different groups of people, to look at this issue, because it's one that has been ignored for far too long, and that's the issue of Black maternal health. Now, would have heard the really shocking figures that Black women are 4 times more likely to die in pregnancy and childbirth. Women of mixed heritage are 3 times more likely, and women of Asian heritage are 2 times more likely. And that is no small thing. And the care that a woman receives during her time, not just in hospital when she's giving birth, but everything leading up to, makes a massive difference in terms of the outcomes, and not just for her health, but also for her child's health. And I think it's really good that we're doing this on the International Day of the Midwife, because a good midwife makes all of the difference. And I know that there are many amazing midwives right across the country. I also know that there are many Black midwives. So it's been quite interesting when talking about this issue. People have made the assertion, well, how can you say that the NHS is engaging in any type of institutional racism when there are so many Black staff members that work within the NHS? But that, I think, is a fundamental misunderstanding of institutional biases. When an institution is biased, regardless of its makeup, the message that is sent from the top and the message that is communicated throughout the institution goes right through everybody that works within it. So that means when it comes to training, when it comes to talking to people, when it comes to looking at this issue, all members of staff need to be looked and need to be taking this on board regardless of what they themselves look like, because working in that particular institution means they may be in some ways going along with this bias in themselves and perhaps by the directorship they are given. Now, since the 2019 Embrace report highlighted these figures, and others have since, we have seen so many different discussions about this. Unfortunately, we hadn't seen as much attention as we wanted around the subject until it came to the very, very timely debate in Parliament that highlighted and was a result of the campaign group 5 Times More's petition which had 187,000 signatures right from across the country, but was taking some time to get put on the book. So it was victory for the first time for it to be heard in Parliament. But during the week before the debate was heard in Parliament in the US, they were having their Black Maternal Health Week, and it was for the first time that their government was actually acknowledging the issue. You had the Vice President leading a roundtable with organisations across the country, and you saw a statement from the White House acknowledging it and pledging to do more. Not just that, I think $200 million was also put towards the type of training that you have been talking about today for healthcare professionals right across the country. And that's such a massive difference from what we have here. We have a recent race report that acknowledges these issues, but actually goes on, and the Equalities Minister said the number is so low, it's difficult to tackle it strategically. And I hear that coming from the very top, that disappoints me, because I know that there are trusts, there are hospitals like Croydon that are actually taking a strategic approach to this and actually looking at how they can make changes. As you've heard already before, there's enough conclusive evidence as to exactly what happens that makes these really, really distressing outcomes. But it's very clear from talking to Black women, it's very clear from the figures that has to be done. And when Black people say they're not being listened to, we don't need to wait for another report. Yes, more information needs to be gathered, but we don't need to wait for that to take the time to stop, check our biases right throughout the institution, and actually take action in the way that you're doing by listening to that call and making sure that women are heard. Because I think about my own experience, and whilst I did have access to people throughout the NHS who were kind to me, who were helpful to me, particularly towards the end, I didn't have the best necessary experience right at the beginning. I think from the midwife I first visited, who told me I was going to have a beautiful baby when she thought my baby was going to be of mixed heritage, to the 111 clinician who I called at one point when I wasn't feeling too great, who told me that his mum had gone rock climbing when she was pregnant with him, so he was sure I was okay, to the consultant, another midwife, who sent me home when I'd been flagged for a blood test because of a urine. I'd been flagged for a scan because of something that happened with the urine and blood test, who seemed more concerned about the fact that I wanted to know what the gender of my baby was. And I could see were having some discussions about the headscarf that was on my head, which was purely there because my hair was messy. But we know that there are certain preconceptions about some cultures and gender selection. And all of that culminated in a very, very late diagnosis of preeclampsia. And you all know better than me probably what can happen when it comes to preeclampsia and when it's diagnosed late, and the threat that it can have on both mother and child. And I had a very tough experience where my blood pressure would get so high, but my nose would bleed. I was swollen. I was so unwell by the time it got to the end, and I was told that there was nothing really that could be done to save my child. And if I continued with my pregnancy, that it was a threat to myself, and that was obviously very, very difficult to hear, especially with them telling me that actually I would have to go through a late termination in order to save myself. And it's hard to hear all of these things, especially when you know that you've raised issues before. And because of the job I do now, and because I spend a lot of time speaking up for people, I spend a lot of time advocating for people, I look back and I think to myself, I could have advocated better for myself. And you know that people, a mother would always in this situation perhaps blame herself, think what if I'd done this, what would I have done that? But we have a National Health Service, and I believe that every single person that works in that National Health Service should be advocating for me. Yes, I can stand up for myself. Yes, we can all be better informed. And that's one thing that Black women have talked a lot about, not being better informed. But I expect to be advocated for, you know, in a situation where my first pregnancy, it's been my only pregnancy. I did not know a lot before then. I didn't know enough. And if people had advocated for me, I would have had a much better outcome. And I want to make sure that, you know, from now on, to stop this, because we have a situation, my child was stillborn, where Black babies have an 121% increased risk of being stillborn. And you know, for government to say that's not, and the amount of Black women that are dying, that's not a high enough number, actually makes me sick. Makes me think to myself, did my daughter really have a chance with figures like that, knowing that she would be a Black baby? And that's what happens to Black babies in this country. 121% increased risk of stillbirth and a 50% increased risk of neonatal death. That's not something that we should be taking lightly at all. So it's so important that HERD is being launched today. It's so important that, you know, whilst people take the time to you know, look into further research, whilst they take the time to do that, that you're actually listening and waiting to hear what women's concerns are when they're in perhaps one of the most vulnerable conditions of their life. It's so important. So I'm pleased to be here with you today, and I'm pleased that this is going ahead, and I hope it will be replicated across other trusts. I know that Guy's and St Thomas's have taken on the 5 times more training as well, and are just as you have, they have those pins that are explaining to women that, you know, if they come and speak to this individual, they have had the training and they will be heard. It will make such a massive difference. Thank you very much.
Thank you, Belle, for sharing your story. And I'm really sorry about your experience on behalf of healthcare workers. That should never happen. And you know, it really was heart-rending, your story, and we hope it never happens to anybody. So thank you for sharing that with us, and thank you for being an advocate. And I think one of the messages from today is that each one of us need to be an advocate for women we serve. And I think if we all decide to do that, we'll make the world a much better place. But there are tons and tons and tons of questions over here, and I'm really pleased there's so much engagement. But I think there are lots of congratulatory messages out there. So Helen, Olamide, Gina, who's not here, but I think she is somewhere around. Thank you so much for doing this, and we are very, very proud of what you have done. I'm going to just quickly go through some of the questions. Have you got any data on asylum-seeking mothers? I think that's something we need to look at. Dom, you had some really interesting data over there, but do we have a breakdown of Black Caribbean and Black African within our data? Because we know that the outcomes are different.
Yes, we're able to get the difference between Black Caribbean and Black African, and that's something that we're going to be working on in terms of making, especially with the Darcy Fellow coming, having a full report on our outcomes. In terms of asylum seekers, I think that's work that we need to very much focus on, because in terms of the breakdown in the tick boxes, that's very difficult to ascertain. I know that we've got our midwife, Amuna, who focuses on them, and that would be something that we could involve her in data collection. So I think it's something that we're going to look forward to involving her with.
Absolutely. And I think the Darcy Fellow is going to initially work in Croydon and subsequently do the project in Southwest London. So the Croydon is going to be like pilot, and I think we'll get some really rich data. But I totally agree that if we don't know what our problem is, we can't solve it. So many congratulations to you, Dom, for looking at that data, as brief as it may be. And Helen, that survey really gives us something to start off from and frame what we want to do. So well done on that. Victoria has something to say over here, and she's asked, it would be good to understand what HERD is doing, and I think they are going to run some local service user surveys. Yes, so we are going to do some surveys. And there was a question about, is the survey in different languages? Olamide or Helen?
I can answer that, that's fine. The survey, we are struggling actually with SurveyMonkey to get it translated into the different languages that we need, although it's something that we're working on. One of the ways we're collecting data is actually by, we've got an iPad, which we are physically taking to women who are being discharged from their postnatal care. So we know that they've had the full kind of breadth of experience of their care, and we are able to use Language Line to go through the survey with them. It's not ideal, but actually getting the translation onto SurveyMonkey is very challenging, but that's something that we're mindful of. Somebody else asked about the 5 times more maternity experience survey. So obviously they 5 times more have done such amazing work in this area, and they're a massive inspiration. We can share their survey on our social media, but for us it was really important that we hear from Croydon's women specifically as well, and that we are asking, as well as all the Black women that we care for, the Asian and minority ethnic women too. So yeah, hopefully that answers that.
And when we look at data, there's a question about the adverse maternity outcome investigation. So I guess that could be something like SI or even just the other investigations that we do. Do we know if there's a discrepancy in those? Have we looked at those?
I don't think we do. And one of the things that I've been discussing with our risk manager is changing the way potentially that we report the data on our maternity dashboard. So if we could have the dashboard data presented with ethnicity breakdown for each of the parameters on a monthly basis, it would be really beneficial. Yeah, it would be really beneficial going forwards.
And I guess this question is to Olamide. What was the key driver for starting this work? Was it national data or was it locally driven?
I think for me, it was the Embrace report, so nationally driven, because year after year, it was found the similar results. Black women were 5 times more likely, and actually looking at the data from the CMACE reports in 2007, Black African women at that time were 6 times more likely. So I basically thought, I'm a midwife here and I want to do something different. I spoke to other midwives who also shared the same feelings. I spoke to Helen, I've spoken to Gina, and then we started this amazing group of staff who are here to make a difference. That's how it started.
Great. And do we know whether Croydon is an outlier compared to other trusts? Do we have any idea?
I know that, as Belle mentioned, Guy's and St Thomas's are doing some work, and I've sat on other webinars where people have shared really great examples of good practice in this area, but I think I don't know how widely on a national level trusts are working on this issue, but I know that other people are doing some really good work.
Yeah, there is also Barts who have Turning the Tide. That's also some great work that they've done. I think more NHS trusts are starting to do work around it. People have emailed me about the work that we're doing. So I think actually as a whole, hopefully more trusts take it on, and we'll be able to do work nationally as trusts to improve outcomes and experiences.
Absolutely. And what do you think success will look like? What will make you feel that you've made a difference? This is a really great question.
So I think for me, I think it's first of all ensuring that women have better experiences as well. I think that's something that we at Croydon can look at. So doing a service user survey and then having a follow-up survey in a few months or 6 months to see if women feel differently to how they felt now at this time, if they have better experiences, did they feel listened to, was language line used, asking all those really important questions that we ourselves can collect. I also think, looking at, we spoke about the Darcy Fellow, looking at data, I don't know, in a year or 2 years, I think it's going to take time to make change, but we are making the necessary steps. Hopefully that also the Darcy Fellows statistics will help us in looking at what to look at next and how we can, maybe have targeted actions. But that's for me. I think, I don't know if Helen has anything else.
I guess we could pick up a few outcomes, salient outcomes, and then keep a dashboard over years, because change won't happen in a year. Change will happen in 5 years. I probably will hopefully still be around to see that big change that happens. So I'm really hopeful about that. This is another great question. Are we looking at readmissions after delivery based on ethnicity?
I think it's something that we should look at, definitely, especially where sepsis is involved, which we've already highlighted as an issue, but also neonatal readmissions as well. So the care that's being given in the community and advice that's being given to help people initially care for babies. So I think that's something that we will be looking to collect.
Yeah. And Sandra very nicely showed us how there is an intersection with sexual health. And therefore, I guess you could say Sandra is one of our herd champions. Do we need to work with other specialities within the hospital? And are you interested in getting champions? For example, medicine, surgery, and other specialities? Should we be talking to other CBU leads, for example?
I think it would be a great discussion to have. We do need to highlight, the inequalities, and I'm sure, well, I feel like these inequalities may present in other specialities as well. So I think it would be a great discussion to have. I think we've worked so well and so hard to try and improve maternity, but why not? Why not go bigger, and why not, allow people to do that in their own area? So I think it's a great discussion to have. Hopefully, the more the herd campaign gets out there and more people hear about it, that they will actually feel the need to do it in their trusts or their areas and implement something where they can look at this as well.
So I suspect there may be other things happening even in orthopedics, for example, but they just probably haven't looked. And I think, I mean, I have heard that if you look at elective operations, if you look at orthopedic operations, for example, there are discrepancies out there, and the getting it right first time are beginning to look at this. So there will be some data, and then I think individuals can start looking. But why not start from Croydon? So I guess we need to go out there and talk to our colleagues.
Yeah, I noticed as well that Juliet had commented about liaising with the health visiting team, and I think that would be a really important step. So we will definitely send you an email, Juliet, about getting together on that. Thank you.
Yeah, and it's also about getting the information out there. So if our information is on the website, what about those who live in digital poverty? Love that word. Yeah. What are we going to do about that?
So the information that we have translated them into, at the moment, the 5 most common languages spoken in Croydon. We are looking at ways that we can try and translate them to other languages as well. It's just knowing we need to look at our demographic and see which targeted languages. So at the moment we have Tamil, we have Urdu, we have certain languages. And yeah, it's just, we're going to keep working. Your questions are really helping to help us think about improvements that we can make in the campaign and improve in that way. So thank you very much.
Yes, and what this awareness training that we spoke about, is it going to be part of mandatory training? Can you tell us a little bit more about it?
So we're still in the talks of the training. It is something that we want to be put onto mandatory training, so we know that all members of staff are having it, and they're having it yearly. We're still arranging that with the education team and ensuring that we can get that done. So hopefully soon we can arrange that, but it is something we're looking at.
Yeah. Sandra, this is a question for you. Is Croydon doing anything specific with the council and trust to reduce STIs?
Yes, we have an outreach team at the moment that works in the council premises that we look after and we manage, and they do all the education in the colleges and out there for the council. So we definitely are very actively working with the council in pushing the sexual health agenda forward.
Absolutely. There needs to be work done. And also with postpartum contraception, which is another area I'm very passionate about. And I think we need to look at that. It needs to be available freely for postnatal women. We do know that about 45% of pregnancies in the UK are unwanted or unplanned rather than unwanted. They could become wanted after, but they're unplanned. And we do know the closer the pregnancies occur, there are more poorer health outcomes. So it is again something else that we want to champion as the Women's Network in Croydon. But I think everyone in maternity knows that that's one of my bugbears. So that's the next thing we are going to do. Lots of huge compliments over here. There's a question from Joe to Dominic that she was involved in conversations around this a couple of years ago. And it seemed to be the case that only the data from women seeking asylum and initial accommodation could be extracted via Memuna's caseload. So I think we need to talk to Jo about what more she thinks we should do about asylum seekers. It's a very important group in Croydon. We need to look at that. I think we're coming to the end of my questions. There are loads of questions out there. We have a question from an obstetrician, which I think we should answer. If I can get to it. Abdul has a question here. Do we have any data on differences in mental illness and depression? Very important question, because we do know that there's a huge amount. This is another area where women are ignored because with mental illness in the socially deprived women and also in ethnic minority women. And there is a huge problem with mental illness over there. And the worst thing is it's ignored. So are you looking at that? Are we doing anything? Any plans?
I think, as we spoke about collaborative working, that's something that we can also reach out to, the perinatal mental health team and see what their data is and try and work with them. I think in any ways that we can improve in any specialities, we should definitely try and do that. And that's something that we will look into.
Yeah.
I think that's another area where the Darcy Fellow doing a deep dive in the initial audit that Dom and I looked at for the past 2 years worth of data. I did look at whether women were recorded as having any mental health conditions on our record, and it's difficult because of the data quality, but what I did notice in that initial very, very basic look was that mental health was reported in much greater quantities amongst the white British population compared. Yeah, it was roughly about 25% versus 7.4% of the BAME women. And I think that probably reflects not the incidence, but the reporting. I mean, it's really raw data, but it's the awareness. Are those women able to access the support with their mental health that they need? And are white women more likely to have that help and have it recorded on their notes? So I think that's something we really, really do need to look at and work with our colleagues on.
So I think there is a bit of underreporting because the evidence is out there, and it's certainly an area that we need to look at and probably make it mandatory in our CERNA MIS systems. So we are quickly coming to an end. I think it has been a fantastic, absolutely fantastic. I certainly learned a lot, and I must say I'm really, really proud to be working in Croydon. You have done such a fantastic job, and I'm sure it's going to make a huge difference. I'm going to bring this meeting to an end now. We still have questions, which we will continue to answer, but I've realized that I've really badly timed this, and I've been a poor chair, but I just couldn't. We needed to answer many of these questions. But we will get back to those who have left questions over here and answer all of them. There have been huge number of ideas that we have gained from this meeting, and we'll certainly look at each one of those, discuss them, and make them part of our campaign. So thank you to all our speakers. A special thank you to Olamide, Helen, and Gina, and Dom. We have spent a few afternoons chatting about this, and it's really wonderful to see it all come together in such a short period of time. So really, really well done. A very special thank you to Sandra, my partner in crime, and also a very special thank you to Davina for telling us her story, Belle for sharing your story, and to Beverly and Victoria, who are going to help us shape this herd campaign. Thank you so much. Good evening, everybody. Go and enjoy your evening. Normally, I would say safe journey home, but now I'm going to say have a wonderful dinner wherever you are. Thank you. Thank you all.
Thank you, Ronnie. Bye.
Thank you, Belle. Bye.
Thank you, everyone. Thank you, Val. Thank you, everyone.
Thank you.